My name is Jonathan Paley. I'm a radiation oncology physician in Philadelphia, United States. I work with Rayos Contra Cancer, and on behalf of all of us, this organization, we're very, very excited to have you here and very excited to be leading this course on transitioning to IMRT for both clinicians and medical physicists, first and foremost medical physicists. Today, we're having our first lecture by Dr. Claire Dembski from Calvary Mater Institute in Australia. Thank you very much, Claire, for being with us today. We had a special guest who I was going to introduce. I think he's not here yet. So maybe at the end, we'll have our special guest introduction. But again, this is meant to be an interactive curriculum. We are recording these lectures and hoping that you're able to attend live. And so if you have questions, please type them into the Zoom chat, and we can try to get Dr. Dembski to answer them while we go. And then at the end, there'll be time for questions as well. Okay, and again, these will be recorded, so if you feel like you just needed to review something that was said on a slide, we can give you the ability to do that afterward. These will be getting posted to YouTube. Okay, so again, thank you all for being here. We're very excited about this course. If we haven't had a call with you, your individual center yet, we'll be doing that over the next couple of days and sending you some additional materials. And hopefully you've all also received the schedule for the first month of the course. Okay, without further ado, I'll hand it over to Claire. Claire, do you have presenting ability?
Yes, I can share my screen, I think is the best way to do this. Okay. Hello, everybody, wherever you are in the world, whatever country you're in. Welcome to this program. As one of the educators, I think I speak for all of the educators in saying we're super excited to be able to present this to you. We hope that you find this some way useful, even if just a little bit. It's my understanding that we've got quite a varied level of experience and progress in IMRT treatment and treatment planning. So really what today is about is just introducing you to the fundamental concepts of IMRT and just slowly walking you through the very beginning of it. There may be some of you that have no idea about IMRT, so this is the lecture for you. And as we progress through the course, it gets more and more intense. So I'm just going to ease you into it today, just with some simple information, some background, just to set the scene for the next few weeks as the other educators really dig deep and give you a lot of information in how to successfully implement IMRT in your departments. Okay, so hopefully, there we go. Okay. So look, like I said, some of you, I believe, are already doing IMRT and even BMAT treatments. Some of you are thinking about implementing IMRT. Some of you are a little way off, but want that information so that you can go into the process with your eyes open. So really what I'm going to talk to you today about is what IMRT is. Let me give you some examples of some high yield applications. Briefly talk about the resource requirements for IMRT treatments, introduce you to the concept of inverse planning, and then just some important points and new concepts that you may not have heard of before. Okay. So firstly, what is IMRT? So IMRT stands for Intensity-modulated radiation therapy. So really this is one of the most advanced forms of conformal radiation therapy for external beam. Really the key to IMRT is improved dose delivery to the tumour, correlated with reduced doses to healthy tissue. So that's the real benefit of IMRT. Obviously, giving better treatments, what we end up doing is having better outcomes for our patients. So this results in increased life expectation and better quality of life. Better treatments also mean we have less repeat patients. So we won't be seeing patients coming back with metastases or secondaries. Better treatments also mean much less side effects for our patients. So we won't be seeing those severe radiation-induced complications by using IMRT. And better treatments obviously equal a much less burden on the healthcare system as a whole. So by implementing IMRT, not only are you giving better treatments to your patients, but you're improving the healthcare system as a whole as well. So IMRT is a different way to both plan your treatments and actually treating your patients, compared to what would be 2D radiation therapy and also 3D conformal radiation therapy. So we have improvements in treatment planning through what's called inverse planning. And then we have improvements to our treatment delivery through automation and targeting our tumours in one treatment, and also by using the fact that our healthy tissue is getting less dose, we can then start to dose escalate to our tumours at the same time. So in terms of high yield applications, why would we use IMRT? So by using IMRT, what we can do is actually target complex tumour shapes. So rather than treating a 4-field box of our pelvis or just the outline of our tumour, we can actually really start to target complex shapes. So this means we can conform the radiation dose much more tightly to our tumour. Doing this, obviously, we're decreasing the dose to the healthy tissues, and by default, we're decreasing the complication rates to our patients. By targeting our radiation dose to the tumour, we're also able to escalate the dose of the tumour, which means we can get better tumour control. So we can give a higher dose to the tumour than we've usually been able to give, with reduced dose to the healthy tissue as well. We can also use IMRT to re-treat patients who have previously had radiation therapy and have almost reached their dose limits for healthy tissue surrounding the tumours as well. So that's another opportunity where IMRT can come into practice. So there's been many clinical trials over many, many years that have proven the effectiveness of IMRT over a wide range of disease sites. So IMRT gives improved long-term overall survival with improvements in local control and the lower incidence of late toxicities. So just as an example of the dose distributions on this particular page, so this one we're sort of looking at a whole spine treatment. You can see with our 3D conformal, whilst we're treating the spine reasonably well in this patient, we're also treating a large amount of healthy tissue with our 3D conformal treatment. When we start to look at something like IMRT, you can see that we're targeting our treatment area much more effectively and reducing the dose through a lot of the abdomen of this patient. And then when we move to VMAT, which is a more advanced form of IMRT, we can further target our tumour volume and more reduce the dose to the tissues surrounding it. So that's sort of a nice example of how sophisticated you can get with your treatments with the IMRT and VMAT. Just as some clinical examples, so head and neck cancers is probably one of the key areas where IMRT is super useful. The head and neck area is really sensitive to radiation, and often patients that have radiotherapy to the head and neck area end up with really bad side effects that impact not only their quality of life, but also a lot of these patients require hospitalization from their side effects, feeding tubes, they'll require dental intervention just due to the radiation they're receiving for their cancer therapy. So what we've learned through clinical trials is IMRT significantly improves the 5-year overall survival. It also improves relapse-free and progression-free survival compared to 3D conformal radiation therapy. What we also quickly realized is that IMRT is so good, it ended up being unethical to run clinical trials comparing IMRT to conformal radiation therapy, because if you had the ability to provide IMRT, it was really unethical not to offer it to a patient because the outcomes are just so significantly better and the side effects are significantly reduced. So it's been quite a while since we've had any kind of conformal versus IMRT clinical trial, just because the benefits are so significant against the risks. So again, in these images, you can see, even with a really good 3D conformal plan where you're targeting your tumour volumes quite nicely, you still are giving dose to areas outside the target volume, and particularly in the head and neck region where you've got the parotid, you've got salivary glands, you've got a whole bunch of other things that are super radiosensitive. So by using IMRT, we can avoid those areas altogether and really target what we need to treat. I see someone's raising their hand. I'm not. I can't see any comments though. Okay, I might just pause in a little while and see if anybody has any comments. Oops, I just need to go back. Okay. Another example where IMRT is really helpful is in pelvic cancers. Just wondering if I can move that to the side a little bit. Not really. Oh. So in pelvic treatments, you often get really severe bowel and bladder complications due to radiation therapy treatments. So by using IMRT, again, we're protecting the healthy tissue from radiation damage. So we're protecting against those rectal and genitourinary toxicities compared to 3D conformal. And particularly in the pelvis, IMRT allows us to give higher doses to our organs, our tumours, which in cases like the prostate are needed for biochemical control of the tumour. So IMRT allows us to give much higher doses to our tumours. So again, it might be a bit hard to see. I'm not sure if you can see under there. We've got an IMRT treatment of, this looks like a cervix with some nodal involvement. And you can see the IMRT, we're completely sort of sparing the bladder and the rectum in these treatments compared to your conformal therapy treatment. That's better. So some other examples of high yield applications. Brain cancer is another obvious one because there are so many sensitive areas in the brain, and IMRT will improve the radiation dose conformity. It will allow you to spare critical areas in the brain that could otherwise lead to radiation damage, which could be loss of respiratory function, paralysis, loss of cognitive function as well, and decrease in quality of life for those patients. And again, with thoracic cancers, doses delivered by IMRT can reduce toxicity in patients that may otherwise require medical interventions due to the radiation damage caused from their treatments. Okay. If someone has a question, maybe we can use the chat function. You can type a question there and we can have a look at those. I'll pause sort of during the presentation. We can have a look at questions if you've got any of them as we go along. So in terms of resource requirements, IMRT treatments are significantly more complex than 3D conformal. So there's a few steps that really must happen in order to safely start treating patients with IMRT. So these things are obviously a thorough understanding of the equipment that you're using and of the needs of the staff and the staffing needs that you need to have to deliver the treatments. Training of all of your staff, so not just your physicists, not just your radiation oncologists, not just your radiation therapists or your dosimetrists, but all personnel actively involved in the treatment. We need to have thorough acceptance and commissioning of any new equipment that you're going to use. And this may also mean recommissioning of existing equipment for use in IMRT treatments. We also need to develop a comprehensive quality assurance program for IMRT treatments to make sure that we're delivering the treatments that we're planning and we're accurately delivering the treatments that we're planning to our patients. So IMRT requires close collaboration of a multidisciplinary team And this includes radiation oncologists, medical physicists, dosimetrists if you have them, and radiation therapy technologists. So there's not one specific discipline that is more actively involved than the other. It is absolutely a team effort to get IMRT successfully up and running. In terms of equipment requirements and department requirements for IMRT treatments, in terms of imaging, a 3D image data set is absolutely essential. So this would be a CT data set at a minimum. If you have access to MRI and or PET, these are obviously super useful in accurately defining your tumour so that you can really get your dose tightly around your tumour volume. Contouring. So contouring becomes a much larger component of treatment planning than it is with 3D conformal or 2D treatments. So we need to have a clear definition of our target volume, and not only that, but also all of our organs at risk. So if an organ at risk isn't contoured, it's not considered by the planning system. So there's a lot more contouring that goes into treating with IMRT. Patient immobilization and positioning is really important because we are targeting our tumour far more accurately and far more precisely with our treatment plan than we ever have before. We need to make sure that we can reproduce that on the treatment unit every single day for treatment. So we need millimetre precision for our treatment delivery, which will require some sort of patient motion management system in place in the department. In order, again, to validate that our patient is accurately set up and ready for treatment, some kind of imaging system at the time of treatment is also required to make sure that the radiation beam is going exactly where it needs to be inside our patient. At treatment delivery, we need to have the ability to deliver modulated beam fluences, and I'll talk about a little bit what a beam fluence is in a little bit. So we need to have the equipment that it allows us to deliver modulated beam fluences. And then obviously quality assurance is something that's super important. This not only allows us to ensure we're delivering high quality plans, but also that we're delivering them safely to the patient. So it's one thing to develop all these super great plans on a planning system, but if you can't safely deliver them to your patient, then you could be doing far more damage than you realize. One of the reasons for this is because your dose is so much more conformal to your tumour volume and your margins are so small around your tumour volume. If your patient isn't set up correctly, not only will you give extra dose to healthy tissue, but you won't be treating your tumour successfully as well. So there's an increased risk of recurrence in those cases. Of money for IMRT treatments. So IMRT equipment that you need to treat IMRT treatments with usually would require a greater initial financial investment. So these are just some figures that were given from an IAEA document, which is now 12 years old. So you can imagine these numbers are significantly higher than they were before. But really the benefit of IMRT is it's so flexible that you could almost get away with a single energy LINAC that was IMRT capable, along with your simulator and planning system. And then let's say a HDR brachytherapy program. So dual energy LINACs, whilst they are useful, more flexibility with IMRT than you do with 3D conformal. So you may well be able to get away with just a single energy LINAC to be able to give some really good quality treatments to your patients. So there are those sort of considerations that need to come into thinking when you're looking at purchasing equipment for IMRT. Obviously the financial investment, you will get returns in terms of you'll have a reduction in recurrences and complications from the treatments you're delivering. So there'll be less of a burden on the hospital system in those cases. And you'll also probably see, if you're in a country that has multiple radiation therapy departments, you may see an increase in your patient referrals. If you're a hospital that can offer IMRT where another hospital can't, you'll probably see that you'll get an increased number of referrals and patients through your department, which is good. And because of the improved efficiency in IMRT treatments, once you have experience with it, you'll also see an increase in your patient throughput. So you'll be able to treat more patients per day than you were treating before as well. So this is really some of the basics about intensity modulated beams. Some of this may be super simple to some of you, but I just wanted to make sure at the very beginning of this course that everyone understood what the key concepts were. So I apologize if this is really basic, but it took me a while to get my head around what all this meant. So it never hurts just to have things reiterated to you as well. So what is an intensity modulated beam when we talk about IMRT? So in a 3D conformal plan, or even a 2D sort of 4-field box type treatment, the radiation beam has a flat profile. So you can see the beam profiles as they're going inside the patient are flat. So what we're saying there is each beam has a uniform fluence. So even if it has a really unusual beam shape and is quite conformal in that way, the inside of the beam has a uniform fluence. So what an intensity modulated beam is a beam that has a variable profile. So you'll see them here. So in this case, say we're trying to target the prostate here, we want to miss the bladder, so we'll have a lower in the rectum, we'll have a lower intensity in the middle here because this is where our rectum is, with high intensity beams on the side because that's where our prostate's going to be for that particular beam angle. So what you'll see is that each beam has a variable profile that's adapted to suit not only the target but also the organs at risk around it. So in this case, we say that each beam has a non-uniform fluence. So in this case, you'll see that there's more intensity of the beam here and less intensity of the beam at the top there. So I've said the word fluence a few times. What is fluence? So really, if you think about fluence, you're really thinking about intensity. So we talk about intensity modulated radiation therapy. Really, what we're talking about is modulated fluence radiation therapy. It just doesn't flow off the tongue as nicely as intensity modulated radiation therapy. So, but it's really the same thing. So fluence is defined as the number of photons that is passing through a cross-sectional area. So if you think about the patient's skin, it's how many photons are passing through an area of the patient at any one point. So it's often, well, it's usual to think of fluence as being equal to dose. So you see a nice fluence profile and you think, oh, well, that's the dose that's going to the patient. Now, whilst fluence and dose at depth have a very strong relationship, fluence can control the dose, but it's not equal to the dose. And this is because obviously at your skin surface and at depths sort of leading up to your maximum dose, you've got your build-up effect. So, but by changing the number of photons that pass through parts of the patient, so by changing the fluence, we can change the dose that that patient receives. So that's quite a key thing to understand, is when you're looking at a fluence map or a fluence profile, what you're seeing is just the fluence. You're just seeing how many photons are passing through, like the area of the patient. So that's not the same as the dose that the patient is receiving, particularly in the build-up region. They can be quite different. So how do we create modulated fluence? So there are different ways that we can do this. Probably the simplest way is by using compensators. And you could even think that a physical wedge is creating a modulated fluence, because if you add a physical wedge into your beam profile isn't flat anymore. So by its strictest definition, a wedged field has modulated fluence. But really, when we're talking about IMRT, we're talking about things that are a little bit more customized for an individual patient than just a wedged field. So, but there are compensator-based ways to modulate the fluence, and certainly there are some departments that use this very successfully. There's a method called step and shoot IMRT. There's dynamic MLCs and also VMAT. So those three methods use the MLCs inside a conventional LINAC to create the modulated fluence profiles that you need to treat the patient. And then we've got more sophisticated things like helical tomotherapy and CyberKnife. We won't be covering those in this course. I think they're a little bit outside the scope of what we're looking at, but I just wanted to acknowledge that they were also ways that you could treat patients with IMRT. Okay, so I'll just, again, if anyone's got any questions or comments they want to make, please use the chat function. I don't think anyone has yet. No, okay, but please feel free to. So like I said, there are three ways that you can use your multi-leaf collimators or your MLCs to create an intensity modulated field. The first one, and probably the most basic one, is called static MLC or step and shoot. So in this delivery mode, the MLCs will only move when the radiation beam is turned off. So you will have the beam on with the MLCs in a certain shape, the beam will turn off, the MLCs will move, the beam will turn back on again. We're all at the same gantry angle. So that's what step and shoot is. You've got dynamic MLC. This can also be called things like sliding window techniques. So again, in this modality, the MLC leaves will move continuously while the radiation beam is on, but while the gantry is fixed in one position. So let's say we have our gantry at 0, we'll have the beam on with MLCs leaves moving into different shapes that we need for treatment while the beam is on. And the last sort of MLC-based form of intensity modulated radiation therapy is called volumetric modulated arc therapy, or VMAT. So this is where the MLC leaves are moving continuously as the gantry is rotating around the patient whilst the radiation beam is on. So this is quite sophisticated. This gives really, really good dose distributions, but you can imagine it's a quite complicated form of treatment. So it requires a lot of measurements and commissioning and a lot of quality assurance to treat a patient using VMAT. So I'll just go through each one in a little bit more detail. So step and shoot, IMRT. So in this sort of treatment, we have a sequence of subfields that are given one after another to create the desired fluence. Okay, so for example, in this picture down here, we've got 4 separate subfields that creates a fluence profile that looks like this. So each of those 4 subfields are given at a single gantry angle. Okay, so each subfield is defined by different MLC shapes, and between each different MLC shape, the beam is turned off. So no radiation is given during the leaf motion. So in step and shoot IMRT, you can have an individual field or individual fluence made up of only a few subfields, so 2 or 3 subfields, or you can have a beam fluence that's made up of many subfields, so let's say 10 to 20. The thing about step and shoot IMRT is you can do forward planning or inverse planning for these type of treatments. So this is just another example where we've got a single MLC shape that's been created, and these are all added up together to create the fluence that you need to treat the patient at that particular gantry angle. Okay, so dynamic MLC or sliding window. In this case, what happens is a sliding window of MLC shapes occur whilst the radiation beam is on, but at a single gantry angle. So in this case, we've got this radiation field shape and then this one, and there's lots and lots of shapes that are all added up together to generate the fluence that you need for that patient at that gantry angle. So basically, in sliding window, the radiation field is made up of many, many small subfields. Due to the nature of sliding window treatments, it's not really intuitive to plan these. So you can't really plan these as a forward planned treatment, but you need to use inverse planning to treat these type of patients. So both step and shoot and dynamic MLC IMRT treatments use fixed gantry angles during the treatment with multiple beams or subfields at different gantry angles contributing to the overall dose to the patient. So you can see in this example, we've got 5 different gantry angles, and each gantry angle has multiple subfields that make up the treatment to deliver the dose to the patient. So volumetric arc therapy, or VMAT. So this is an arc-based treatment delivery. So what you can see in this example here is the gantry is rotating around the patient. These are the MLC shapes that are being created by the MLC leaves as the gantry moves around the patient. So they're all our separate subfields. And this is all happening while the radiation beam is on. So you can deliver an entire treatment, sometimes in a single rotation around the patient. Sometimes you have to use multiple rotations around the patient, depending on how your dosimetry looks. So the gantry is rotating, the MLC leaves are moving whilst the radiation beam is on. Again, you can see the odd shapes, the odd field shapes that you're seeing as part of this treatment. So there is no way that you can manually plan this type of treatment or forward plan this type of treatment. No matter how good you are at planning, there is no way you'd be able to predict what kind of field shapes you need at each individual gantry angle. So again, in this type of treatment, inverse planning is used. So again, for VMAT, we have our arc that's continually rotating around the patient. So we now don't see those entry points of beams through the patient. It's more of a smear of dose that goes around the patient. So during treatment delivery, what we see are changes in field shape. We also see changes in the gantry speed and the dose rate. So gantry speed and dose rate will change during treatment because the MLC leaves can only move at a certain speed. So if you need to have something that's highly modulated with a lot of changes in the field size, the MLC leaves can only move so fast. So in order to compensate for that, you might find that the gantry speed reduces or that the dose rate reduces, so it gives the time for the MLC leaves to get into the right positions that they need to be in. So looking at 3D conformal versus IMRT. So by IMRT, I mean probably a sliding window IMRT versus VMAT. In terms of dose conformity, doses to organs at risk and treatment time. In terms of dose conformity, both IMRT and VMAT are superior to our 3D conformal radiation therapy treatment. You just can't get this kind of dose shaping that you see in IMRT and VMAT using a 3D conformal treatment. It just doesn't happen. In terms of doses to our organs at risk, VMAT is superior in most cases to IMRT, and IMRT is superior to 3D conformal. The reason that VMAT is better than IMRT is because, again, you've got the smearing of dose around the patient. So rather than having those hot entry points of individual gantry angles, you might have a bigger low dose wash throughout your patient compared to IMRT or conformal radiation therapy. In terms of treatment time, depending on the IMRT treatment that you're doing, you may actually have an increase in treatment time. And this could be because you've got highly modulated fields and a lot of gantry angles. if you want to get the best dosimetry. So this means you're treating patients with a lot more monitor units than you would standardly treat. So in terms of treatment efficiency, IMRT can sometimes be a little bit slower than 3D conformal, but the gains in dose conformity and doses to organs at risk far outweigh what would be a slight inefficiency in treatment delivery. VMAT, because you've got the gantry moving in MLCs and you can get a treatment done in a single arc, the treatment time can be greatly reduced compared to conformal radiation therapy as well. So I've mentioned things like forward and inverse planning. So I really just want to go over what the differences are between these two things over the next few slides. So forward planning is where we're defining our fields and then trying to figure out what the dose is to our patient. So we say, let's give 100 monitor units with a square field at this angle, and then a wedge field on this side and a wedge field on this side. Let's give it 150 monitor units or some kind of weighting. What dose are we getting to our PTV now? So really, that's what we're doing in forward planning, is we're adjusting our fields to find out what dose we give to our organs at risk and our PTV. In inverse planning, we're doing the opposite. So we're saying, I want to give this dose to my organs at risk and my PTV. And then what the computer will do is go out and tell you what your field should look like. So it's the reverse situation. Forward planning, you're putting your fields into the planning system. It's calculating what the dose is. Inverse planning is you're telling the computer what dose you want, and it's calculating what fields you need to generate that kind of treatment. So that's really the key difference between forward and inverse planning. So when we're doing a forward planned treatment plan, we need to manually define the prescription dose, obviously. We need to define the PTV and the organ at risk volumes through contouring. We need to define what the beam directions are. We need to define the field shapes, and we need to define the beam weights. And so in order to improve the dosimetry of a forward plan treatment, the planner needs to adjust beam shapes, beam weights, and beam directions in order to improve the plan for that patient's treatment. So in an inverse plan, what we manually define, again, is our prescription dose. And again, we need to define our PTV and organ at risk volumes, so our contours there. What we define in an inverse plan is the dose objectives for our PTV and our organs at risk. So we'll tell the computer what doses we want to be giving that. And we can also define the beam directions in some cases. What the computer then determines is what field shapes and what beam weights you need to deliver the dose. So in an inverse plan, the planner will adjust the dose objectives and the contours of the plan in order to improve the dosimetry of the treatment plan. Okay, it's quite a bit to get your head around. It took me a long time to figure out this particular slide. So you'll get a copy of these slides so you can go back and have a look as we go through. So when can we use forward planning for IMRT? So I mentioned before, some treatments can be planned using forward planning, and that's great. If you don't have an inverse planning option on your planning system, you can still do IMRT, but you can only do it for step and shoot IMRT. Remembering step and shoot is where your MLC leaves move only when the beam is off. Okay, so I'm just going to give you an example of how to do a forward planned IMRT treatment for a breast case. There are some departments that still use this technique, even though they have inverse planning, because this technique is so simple and so effective. So it's actually quite an easy way to get started in basic IMRT treatments. So what you do for a breast treatment is you create a standard 3D conformal plan. So you'd have your two opposing fields going on your breast. You would copy the beam. You draw a new segment by blocking areas of high dose, and you'd repeat that for each individual beam. then you'd adjust beam weights to achieve the desired dose distribution. So I've got some pictures here to help explain a little bit better. Okay, so here's our initial dose distribution on a patient's breast treatment where we've just got parallel opposed fields, no wedges. So no wedges at all in these two fields. And you can see you're going to get hotspots near the surface of the breast, which is not good, but that's sort of a typical dose distribution you'd see on a breast treatment. So what we'd then do is create some new segments or subfields using that open field dose distribution. So here's the open beam that you've used before. You'd then look at the 115% isodose line and you'd actually block that out of the beam. So you're blocking your 115% dose and creating a small field outside of that. You'd then do the same thing with your 110% dose and create a small field, and the same thing with your 105% dose. So you'd end up with this sort of skinny field like this for your treatment. What you'd then do is you'd adjust the weights on each of those small segments in order to optimize your plan. And so this is a sort of dose distribution that you can then come up with for your breast treatments. So you still are going to end up with a slight hotspot at the skin surface. It's really difficult to avoid, but it's certainly a lot less than you were seeing with that just open field plan. And you can see your 100% isodose has got beautiful coverage throughout the whole of the breast volume. So that's a really simple way to do forward planned IMRT using step and shoot with your MLCs. So forward planned IMRT, there's not a great increase in the complexity of treatment planning. You've seen, just showing you how simple it can be, or the treatment delivery. So for each gantry angle, you're delivering 4 fields instead of 1, really, in the delivery process. What you need to be careful of when doing forward planned IMRT is generating really small segment field sizes, particularly if your planning system and your LINAC haven't been commissioned for this. So if you haven't commissioned your planning system or your LINAC to deliver a 1 centimetre wide treatment field, then you can't be sure that the dose your planning system is calculating is being delivered on the LINAC properly. So you may need to recommission your planning system and LINAC for these smaller fields. Okay, but once you've established this system and you've verified it, it doesn't really require a great deal of additional quality assurance. So that's the beauty of these type of forward planned IMRTs. One thing I have to stress is that forward planned IMRT is not a substitute for inverse planned IMRT. You can't get the level of, I guess, organ at risk sparing or dose conformality with a forward planned IMRT treatment that you do with inverse planned. It's just impossible. But it is a nice way to improve dosimetry in cases where you don't have access to inverse planning IMRT. So what makes inverse planned IMRT treatments different to forward planned IMRT treatments? So like I've said before, you get greater dose conformity due to improved plan optimization processes. The problems with IMRT inverse plan treatments is it's more difficult to spot planning errors because those field shapes and weights are so unusual. It's really difficult to know if there's something wrong in the treatment plan. So your plan quality assurance needs to be far more structured and strict than with a forward planned plan check. Obviously with inverse planned IMRT treatments, it's more difficult to do in-field imaging. If you saw the sizes of those subfields, there's no point having MV image of that subfield because all you're going to see is a 2 by 2 centimetre square of greyness. It's not going to give you any reference as to where that is inside the patient. So that's one problem or challenge with IMRT inverse plan treatments. There is, in general, more monitor units given for IMRT inverse planned treatments. So it's less intuitive. So you can't say, okay, this patient's getting 2 gray, we should be 200 to 300 monitor units. You might find for a 2-gray treatment, you're at 600 monitor units. So it's more difficult to spot errors and inconsistencies in inverse planned treatment plans. Again, because you've got this dose conformity, organ motion really has an unpredictable effect. So you either need to compensate for that in your margins around your PTVs and also in your patient immobilization. And the last thing is the deliverability on the LINAC can be questionable. So you can create the world's greatest plan on your planning system, but it may not be deliverable on the LINAC. You may find that your MLC leaves need to move so fast in so many different positions that the LINAC can't physically do this. So that's one of the issues as well. I've just got a couple of questions. For the IMRT, is the dose rate fixed? So for a step and shoot IMRT, yes, the dose rate is fixed because the beam is only on when the MLCs aren't moving. For dynamic MLC, the dose rate is not fixed, but you won't find it dropping or changing as much as you would with a VMAT treatment, if that helps. The next question is not in English, so I don't quite know what it's asking. And then additional comment, the breast forward plan step and shoot IMRT example you've explained is, yes, commonly referred to the field technique. Absolutely, yes. And then there's another question, if someone can translate that for me, that would be awesome. So we might come back to those two. If I can get a translation, that would be great. Okay, next question. Okay, so I'm just going to quickly run through the steps in creating an inverse plan. So we need to do contouring, adding beams, objectives and cost functions, objectives and weights, optimization and deliverable fluences. So I'll quickly go through all of the steps involved in generating an inverse plan. So probably the most important one is contouring. So all tissues of interest must be accurately outlined. So if a tissue is not contoured or it's not specified and dose isn't specified to that tissue, then dose to that tissue is unpredictable in the planning system. The planning system won't know if it's an organ at risk or a target. It will just give whatever dose it needs to give to that tissue in order to give the right doses to the things you have specified. So like I've said before, contouring becomes a much bigger deal in inverse planned IMRT because you need to define everything. Because the computer's generating the fields, it doesn't know whether something is supposed to be avoided or supposed to be targeted. So unless you tell it. So with things like your GTV, CTVs, PTVs, ITVs, you really need to put a maximum and a minimum dose criteria in your optimizer or in your planning system. Obviously, it's logical to set a minimum dose criteria. You want 98% of your volume to get 95% of the prescription, that's fine. But if it doesn't know that you have a maximum of, let's say, 107, 110% of the dose, it might give you 150% maximum. So it's really important to define both the maximum and minimum dose criteria for your PTVs. For your organs at risk, it is essential that you define a maximum dose criteria, whether that be for the whole organ or for a partial volume. And then obviously, depending on the planning protocol that you're using and the doses that you're trying to achieve, you can also specify things like mean doses as well. So the dose criteria that you give to your targets and your organs at risk are translated into things called objectives. And these are the things that the treatment planning computer is aiming to achieve by generating the fluences for the individual fields. So for an IMRT treatment, I'm not talking about VMAT at the moment, generally you choose an odd number of beams or gantry angles for your IMRT treatments. And the choice of beam direction is important. Obviously, if there are avoidance areas that you don't want the beam to be passing through, make sure you avoid those. The key point is you want to avoid parallel opposed beams, because this will increase dose to the organs at risk through entrance and exit doses. So you tend to find that odd numbered beams are more effective in IMRT treatments rather than just having 2 beams or 4 beams. So objectives and weightings are dose requirements that we must achieve or we would like to achieve. So the computer algorithm isn't intuitive. So like I've said, if you've got poor contouring, what you may find is you've got a target volume that's overlapping with an organ at risk, and it's going to have opposing objectives. So the computer's going to look at this volume and go, well, you want me to give it a minimum of 95%, but you've told me you want no more than 50% to this volume at the same time. So the computer doesn't like that at all. And sometimes if a volume doesn't have a dose objective, the optimizer can assign it to a really high dose. And so what you may see around your PTV is a ring of high dose around your target volume. It does this so you've got this nice homogeneous dose inside your PTV, and you haven't said what goes outside of that. So it's put all this hot dose outside the PTV to make sure that your PTV is perfect. So with IMRT, you'll find you're creating contours that aren't even organs at risk or PTV. They're these contouring structures that you're using purely so that the computer gives you a good dosimetry. And all of this will be covered in much more detail in lectures further down the track. This is just sort of an introduction to get your head around the different things that you're going to have to think about in terms of IMRT planning. So the relative importance of all these different objectives has to be assigned, and this is what's called the weighting factor. So if there are things that must be achieved, so for example, your PTV must have a minimum of 95%, then you will give that the highest weighting factor. That means the computer's going to work the hardest to achieve those things, as opposed to something that has a low weighting factor, which you've said to the computer, well, it would be nice to have this, I would like to have this, but it's not essential as much as this other thing that has a high weighting factor. So what the computer then goes to do is it looks at the optimization algorithm and generates a cost function. So what the cost function is the planning system will calculate dose at points within the patient volume and work out the cost function. So if the dose at those points meets the objectives that you've given it, the cost function will have a value of 0, and that's perfect. If the dose doesn't meet the objectives that you've given it, the cost function will have a value that's sort of equal to the dose difference squared. That's a simple way to put it. There's obviously far more sophisticated algorithms, but that's the simple way to consider it. So the idea in inverse planning is to find the beam fluences, not the dose, but the beam fluences that generate the lowest cost function to best meet the dose requirements that you've put in the system. So you're trying to find a global minimum in your cost function algorithm, and that means you've got the best plan that the planning system can possibly generate. This is achieved by performing thousands and thousands of iterations to determine the best beam fluences. So all of this goes on in the background, and this is why when you hit optimize on the planning system, it takes a long time to generate that plan. Hit optimize and go and make yourself a cup of tea or a coffee and come back, and hopefully the computer has done something. But optimization in the planning system can take a significant amount of time. Okay, so we've got to the point where our optimizing algorithm has determined the optimal beam fluences. We've reached our global minimum in our cost function. The computer's gone, these are the fluences you need to have at each individual angle, perfect dose. The problem is that the linear accelerator may not be able to accurately deliver it. So the idea is that you run this ideal fluence through a leaf motion calculator or a leaf motion sequencer. And it produces the best match of the beam fluence with the minimum number of MLC segments. So there's no point creating this perfect plan if it's going to take you 3 hours to deliver it, because you've created 50,000 individual beam segments. So there's a trade-off. So what the leaf motion calculator will do is go, okay, here's a realistic number of segments that we need to create this fluence. Here's the MLC leaf positions that we can do to create that. So then once the leaf motion calculator has done that, the beam fluences will be recalculated. So what you will find is the final fluence that you get in your planning system will be slightly different to the ideal fluence that you've received prior to that leaf motion sequencer being run. I'll just pause again. There's some more questions. Okay, so what should be done in cases where the organs at risk intersect with the target volumes? So that's a clinical decision that needs to be made by the radiation oncologist, where they need to decide whether dose to the target is more important than dose to the organ at risk, or whether the target infiltrates the organ at risk. So you can't have a target and an organ at risk being the same volume. You need to choose whether it's an organ at risk or a target. So really that's a radiation oncologist decision. And I believe there are several contouring sessions that the radiation oncologists are going to be given, where they'll work through that particular problem as well. And then another question. Oh, okay. Okay, so John's just answered that as well. Perfect. Okay. Perfect. Okay, I've just got a little bit to go. I can't seem to get my mouse to work. Oh, there we go. Sorry, just a couple more slides. Bear with me for a few minutes if that's all right. I don't even know what the time is. So in summary for inverse planning, and look, this is very general, this is very basic. All of this stuff will be covered in much more detail throughout the course. So this is just an introduction to get your head around some of these concepts and the differences between forward and inverse planning at the very beginning. So in summary, for inverse planning, contouring is vital. Okay, contouring is going to require extra time and input from the physicians. Both the targets and the organs at risks are going to need to be contoured, and you are going to need additional planning structures to be contoured as well to improve the dosimetry in the planning system. So clear clinical specifications and protocols are essential. So in order to improve the efficiency, you need to develop planning class solutions for consistency. So you will have a set of contours and objectives for all your prostate patients, and you use the same objectives and weights for all of your prostate patients to begin with, so that you're all starting on the same page, that nobody's rethinking individual objectives and weights and what contours need to be in a plan. They've already been written out. You've got this class solution. You need to define really good plan evaluation criteria. So just achieving those dose objectives that you've set out in your class solution is not good enough. Okay, you need to go back and you need to look through your PTVs. You need to look through all your contours and all of your slices. Don't just look at your DVH, but look at your DVH and your contours on your data set as well. So you need to know and understand your planning system algorithm. And again, this is going to be covered in more detail during the course. So things like heterogeneity corrections. What happens when your PTV is sitting close to the skin surface and you've got a lack of backscatter? What happens if your PTV is in the build-up region? How accurate is the dose calculation at that point? So you need to know how accurate your planning system algorithm is to know how accurate your treatment delivery is going to be. Okay, and the final sort of key point is always, always, always check the deliverability of the treatment plan. Patient-specific QA must be completed on every single patient plan. It adds a lot of extra work, but it can be streamlined, it can be made efficient, but this is where accidents happen. If you look at the IAE, a document of radiation accidents and incidents, treatment planning accidents are a huge factor in radiation incidents. So you must always check that the plan you've created in your planning system can be delivered safely on the LINAC. And so this needs clear and justified acceptance criteria to determine whether your plan is acceptable to treat a patient with, or whether it's not good enough to treat your patients with. So this has sort of been the introduction to this course. So what this course is all about over the next X number of weeks, quite a number of weeks, is that IMRT is significantly different in both treatment planning and treatment delivery than 3D conformal radiation therapy. So it requires changes to clinical practice and thought processes that extend beyond what you've been used to in 3D conformal treatments. So sessions in this course will cover the fundamental topics, and they're targeted at both physicists and physicians. So there'll be joint sessions, and then there'll be individual sessions for the different disciplines as well. So when you finish this course, you'll have an appreciation and understanding of the differences in IMRT treatment planning, delivery and QA, and the knowledge of the requirements for safe clinical implementation. And you'll also have a network of invested experienced staff who are always available for continuing support for these advanced radiation therapy treatments. So that's myself and every single one of the educators involved in this program. We don't stop just because we've finished our lecture. We're available at any time for questions or chats, or if you've got any concerns. We would love to hear from you with any questions, and we're here to help. We're all colleagues, and we all just want to give good treatments to the patients that we have. Just a couple of references and the web links for those, and these are really just for transitioning into IMRT and initial implementation of IMRT in your department. Obviously, some of you are more advanced than this, but they're also useful references for you as well. So I'd suggest having a look at each of these. And I'll just check. Oh, there's lots of chats now. Yes, so the slides from this presentation will be given to RCC, and they can be emailed out to all of you. And as John has already mentioned, the presentation is being recorded, so it will be available on the YouTube channel, and you can watch it to your heart's content. But if anyone has any additional questions, oops, I'll stop sharing. I'm happy to answer any questions.
Claire, that was fantastic. Thank you. A really great overview about a lot of different topics. You covered a lot of ground in a short amount of time.
It's a big area. It's a big area to cover. So.
And you touched on and previewed, all of the topics we're going to be covering over the next several months in much greater detail. But I think this really helps tie things together at the beginning and present a picture of where we're going. Just while you're answering questions, I'm going to pull up a flyer for the upcoming sessions. Again, this should have been emailed to most of your institutions, but I'll leave this up here. The next session is going to be on infrastructure, hardware, and software requirements. It's actually starting 5 hours later than this one started at the time that most of these will be occurring. Again, if you haven't received this already, this is getting emailed out in addition to the calendar invitation. So I'll be quiet now and let you answer any questions that people may have. Thanks again.
I appreciate all of you spending the time and staying online to listen to the presentation. I think the upcoming presentations are going to be really useful to all of you. And this course is designed to be super practical. We're not just going to teach you the theory, we're going to teach you how to do this so that you can walk away knowing exactly what it is you need to do and having the background and the understanding of why you're doing it. So that's sort of the purpose of this particular course is practical. So, but feel free if questions pop up over the next couple of days or weeks or whenever. And John, I'm assuming our special guest didn't come online.
Yes, he'll make an appearance on Thursday.
Okay, right.
Yeah, we have a celebrity guest on Thursday that wanted to greet everyone. So again, it looks like we don't have any specific questions, but there's going to be questions taking at every one of these lectures. So thank you all again for attending the first in a series of lectures, and we'll look forward to seeing you on Thursday. And stay tuned for some links via email for the actual materials that are presented here today. All right, take care, everyone. Have a good day.
Thanks, everyone. Thanks for your time.